day, everyone. Welcome to the webinar for us to discuss ways to accelerate progress toward hepatitis elimination in the Americas. Next slide, please. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. I welcome you all to the webinar. It's our pleasure to be presenting the webinar in 3 languages: English, Portuguese, and Spanish. Most of the presentations will be in Spanish, but for those of you who have not participated in a Zoom webinar before, please just look at the bottom of your screen toward the global interpretation, click on that icon, and then select the channel of your language. We will be recording this webinar in these 3 languages so please tell your colleagues that this information will be available in their preferred language after the webinar for those who are unable to attend today. For those who are not familiar with the Coalition for Global Hepatitis Elimination, we are a community of practice seeking to bring together all the stakeholders needed to achieve elimination for viral hepatitis around the world. We do that by bringing people to share lessons learned, which is what we're doing today in this webinar, providing technical assistance and information on country dashboards for over 190 countries. And through all of this, seeking to elevate and make everyone aware of everyone working on hepatitis globally so that we can engage even more partners to build the capacity needed to reach our goals for hepatitis elimination globally and in individual countries around the world. Next slide, please. This is one of a series of webinars that the coalition.
Uma série de webinários que estão aqui, que foram trazidos para os programas a serem compartilhados e ajudar todos a trabalharmos juntos com nossos metas comuns com hepatites e também oferecendo a mortalidade prematura no tratamento. As áreas incluem, temos a vacinação, principalmente para os recém-nascidos, e também para a transmissão, agendando o programa e se tornando algo mais eficaz em alcançar para a eliminação da hepatite. E todos esses webinários estão no nosso website, que são oferecidos aqui. O programa todo estão aqui, slides que tem um resumo dos capítulos de todas as apresentações.
Including these webinars, and you can also follow us on Twitter for that information, as well as various news reports that we put out as well. Next slide, please. One of the areas of work that we have been doing is developing national profiles to capture the status of hepatitis elimination at the national level, to really reveal the policies, the plans, the programs, the partnerships that are being brought together to achieve hepatitis elimination in a country. You know, what have been their achievements, what's their challenges, and what's their feasible next steps. We have, next slide, please. We have done this as a first stop in the Americas over the summer of this year in collaboration with partners in 6 countries in the Americas, as well as the Pan American Health Organization. These profiles are available on our website, and you'll be hearing from 2 of the countries that have these profiles later in this program. But it really sort of sparked the opportunity to build local coalitions in these countries between civil society, expert clinicians, ministries of health, which we did, but then also to see how we could begin to let others in the Americas know about this type of process of coalition building, information sharing, identifying feasible next steps that make hepatitis elimination more achievable as we all work together and look at to see what are reasonable next steps to achieve our goals. Next slide, please. So that's really, our objective here today is to extend that discussion to see how we can advance progress toward hepatitis elimination by sharing lessons learned, seeing what's possible, what are the challenges, and how we can work together to overcome them. Next slide, please. So it's my pleasure this time to turn it over to two of my colleagues who I enjoy working with very much, and I'm sure you'll be enjoying hearing from them in just a moment. We'll have Dr. Marcello Silva, who is trained in internal medicine and in hepatology. He is the director of the Hepatology and Liver Transplant Unit at the Austral University Hospital in Buenos Aires. He's also president of the Latin American Association for the Study of Liver Diseases. He's joined by Dr. Alexei de la Torre Rosas, who's also trained in internal medicine and infectious disease specialist with additional training at the London School of Hygiene and Tropical Medicine. Alexei is the Director General of the National Center for the Prevention and Control of HIV at the Ministry of Health of Mexico, where she's been developing and leading the national program for HIV and the elimination of hepatitis C. I'm very delighted that they'll be moderating this webinar, and I'll turn it over to Marcello to kick us off. Marcello.
Thank you, John. Muchas gracias, John. Next time, I'm gonna ask you to deliver your introduction in Spanish. You're gonna have a challenge there.
Yeah, I'll work on that for the next one. Yes, I promise.
Okay. Bueno, buenos días a todos. Un placer. Gracias.
It is a pleasure to be here with you. Thank you, John, for this invitation, not only to this webinar, but also to be part of this coalition. It is a great challenge for us as a scientific society to be part of these different plans that aim at having that specialize on public health. We are going to have three different presentations today, and then we'll have a discussion with the different panelists. So the first presentation will be about Mexico, the elimination of hepatitis B in Mexico. It will be carried out by Alexei de la Torre, who is a General Director of the National Center for the Prevention and Control of HIV from the Ministry of Health in Mexico City. Then we'll have another conference called How to Eliminate Hepatitis in Brazil. Dr. Karen, who is the coordinator of the hepatitis viral national program in Brazil. And then the third conference is called What do we need to move forward to move towards the elimination of hepatitis C in Colombia. This will be presented by Dr. Cielo Rios, who is specialist of ITS, HIV, hepatitis from the Ministry of Health and the Social Protection in Colombia. We've invited Dr. Ruben Mayorga from PAHO, Maria Eugenia del Feo Moyano, who is president of the HCV Without Borders Foundation from Argentina. We have Dr. Patricia Vélez Moller, who is co-founder of the Guatemaltec Association for Liver, and Dr. Solange Gerona, who is the chief of the National Program for the Liver Transplant and the Central Hospital for Hepatology in Uruguay. So Dr. De La Torre, why don't you just go ahead and share your presentation towards the elimination of the hepatitis virus in Mexico? Thank you, everyone. Good morning, everyone. It is a pleasure to be able to share this dialogue, this space with you that aims at exchanging knowledge in this region. We believe that we have a great opportunity now. This is how we see it in Mexico, to eliminate hepatitis C. And this is thanks to the progress made on medicines, drugs that are really effective and that are changing the dynamics on protection and to protection of people from hepatitis B. In Mexico, since 1991, we've already started having treatments that were very long and not very effective. The antiviral treatment started coming in Mexico in 2014, but it wasn't until 2017 where in Mexico we had access to the drugs that have direct action against hepatitis. Now, the problem with this introduction of these drugs is that they were only available to third level, very specialized clinics, and they were these drugs were very expensive, which really did not allow to have a real policy towards the elimination of hepatitis C in the country. We had to face a lot of challenges, and so even people that had hepatitis C, if they did not have fibrosis or if they did not meet some of the requirements like age and comorbidities, they were not able to access this drug. It wasn't until 2017 where we started having 2019 where we started changing that vision. The National Health Program in Mexico is very complex, and each one of the institutions would do their own purchases of their own drugs, and that would be very expensive for everyone. In 2019, the whole sector reunited or gathered to talk about the strategies and understand the needs at national level to change this situation so that we can have a program that would be more universal and having a public health program or an aim of covering more people and also educating people on hepatitis, the different sort of hepatitis. Also, we do not want to generate silos. We know that hepatitis needs to be attacked with an integral vision where we include all of the different elements. We cannot think about an elimination of hepatitis without having programs that aim at the vaccination strategies, reproductive and sexual health programs, prevention programs, but also other elements that we know that are important, such as mental health, addictions, substance abuse, attention to people that are in jail, gender equality, avoid discrimination, and encourage inclusion. So these are the different elements that are very important when we want to eradicate this public health issue, including HIV, addictions, and TB. That is how we created a comprehensive program that is patient-centered. In this program, we have different pillars that are paramount for our program. We can talk about universal access to treatment and tests. So the first thing that we were working on is ensuring through this purchase program, this innovating process, to having the drugs at a more accessible price so that more people would have access to treatment and tests. This would be something that would happen throughout the country. The interinstitutional integration of actions and information was the second pillar because we needed to share information. Silos are not good for the country. We needed to change the perspective and changing the care, moving it from the third level to the primary care, where we give people access to treatments and tests. And also have a perspective from the region. Mexico is a very big, very diverse country where there are differences in each one of the states. We have 32 states in Mexico where there are differences in the sort of epidemics that we see in the country. And so knowing this diversity, knowing these differences allow us to know where we have to work the hardest. You can see on the map the really dark red areas where we have a rate of almost 49 inhabitants. And then we see the regions where the problem is the greatest. So we need to center our strategies on these areas. If we want to have a patient-centered program, we need to pay attention to the person. We need to include certain elements that would allow us to do so. We first realized that there wasn't enough information on hepatitis and viral diseases. This was something that both the practitioners and the population in general did not know this information. We need to understand why it is important to have an early diagnosis, because that would allow us to avoid problems in the future. So education is important and prevention is important. We need to go where the people are and also talk to the health professionals. But what we want is to avoid new infections. So we need to think about the other elements that allow this transmission, and also considering the current situation with the pandemic and the substance abuse. So we want to have people working towards the promotion of health. And through this strategy of primary care, we can allow people to have a rapid test. If this rapid test is positive, then we do the viral load sample and treatment to decide which sort of treatment the person will receive. And we will refer this person to a center, a health center. Before, we only had 12 centers in the whole country. I'm going to show you a map that shows you how this strategy changed the situation. If people have a steady condition, they can have this primary care attention. And if they have a more advanced disease, they go to specialized centers where they will be enrolled in a prevention of reinfection program. We have standardized information because really we want to have an epidemic intelligence. We did a lot of things to be able to attain this goal. We prepared the previous implementation of this program. We talked for instance, about the modifications that we needed to do. We trained the whole personnel that were working on this program. We sent tests and drugs to the different clinics. We did a presentation of this program to the governors and ministers of health of all of the country. And we signed agreements that allowed us to continue to move towards the goal. This is a work that we started in 2020, together with the pandemic. We needed to change our strategies, so we decided to start our work with a certain population, people with HIV. We decided to start working with these people because we already have a record of how many people have HIV in the country and that were participating in certain programs. We had the information and we were able to have a follow-up on these people. With that, we were able to roll out the implementation and have an escalation of the program, even though the pandemic was hitting the country. Then we started working on other aspects of the program. We started working with other sort of people, like people that were in jail, people that had a substance abuse problem, people with hemophilia, migrant population, etc. So the previous implementation phase has concluded, and the rest of the key populations continues to grow in the last months of this year. So the training program was an online training for the update on the diagnosis and early management of hepatitis C at the primary care clinics, with more than 100,000 people that were enrolled. And we were very happy to see all of these because we knew that these were people from the primary care sector. We had social workers, we have healthcare professionals that were taking this course. And then we also had people from the second and third level of care. And we had other people that enrolled on these programs. We have newsletters and we have uploaded also webinars on our webpage, and we carry out national campaigns that you can find on the radio, you can find on ads at the different transportation methods, so that we can support them. The mentorship program has been very important because it has allowed us to identify and to see a solution on the gaps, to have a forum to discuss the different cases, to talk about the different clinical cases, to identify the local leaders, to create regional groups, and to give mentorship online for different very complex cases, and to support, give support on the scientific production and research works that are so needed for this program. We have an automized center. It is a hotline where people can call us and we can get back to them and give them follow-up, because maybe they want to have a hepatitis C test, or they want to receive treatment, or if they want to talk about HIV and other sexual transmissible diseases. And with that, we can have data. The peaks that you see on the graphs at the right happen when we have the national campaigns. We understand that giving information and putting this information available to people allows for people to be more interested in these different topics. We would love to have a communication program that is that never stops, but we have to work on that yet. We have standardized information, a standardized information system that allows to identify the different progress on the different regions. We can see the impact that COVID-19 had on the triage that we did throughout our program. And with that, we can identify and we can give follow-up on samples of people and the risk factors at in real time, thanks to this platform. So it is very useful to have this platform, because with that, each state knows the status and they can compare their work to those of others. So I was telling you about the impact and the increase of centers for hepatitis. In 2019, you can see the green dots, where only in a few states we had centers where we could treat hepatitis C. But in 2020, with the changes that we made, we increased to more than 100 units throughout the whole country and in each one of the states. Each state has a clinic. There is at least one clinic, and sometimes even more, in each state that takes care of hepatitis C. And this improves access to people. And each one of the states today, we have given the example of the state of Oaxaca, where they have clinics that can do a rapid diagnostic, rapid tests. In Oaxaca, we have 347 centers for the hepatitis attention, where they can have access to this rapid test and this treatment. Can you imagine moving from less than 20 centers in 2019 to more than 300 clinics in only one state? So we understand that this is something that we can achieve. We've made also progress on the diagnostic of this disease. From each one of the different campaigns, we've really been making a lot of achievement. We are able to identify more and more people. And we know that in the past we did not have a sufficient diagnosis of people, and now we are able to do early detection of hepatitis C in people. This is the progress made in people that live with HIV. In some of the states, they've been able to reach all of the people that live with HIV and that receive treatment, and those who have a confirmation of the diagnosis. And so when we compare the results on the different states, we have a benchmarking, and with that, we can know how we can improve, and we can learn from the best practices of the different states, so that we can move towards the elimination of hepatitis in the country. So having this newsletter, and having this campaign, also, we can move towards the elimination of hepatitis C. We need a vision, and we need different cycles for the improvement and the innovations. We know that there is area for improvement. We're happy with the progress made, but there are a lot of things that are yet to be done. And that's why we're here, because we want to learn from you. We want to learn from the different states so that we can aim at improving our programs. The next steps will be the detection based on a model, a collaboration model with PAHO. the simplification of reports and platforms. We need to give information to the people so that they can make decisions to have a non-reactive rapid test for people at high risk and people that have received treatment, and also understand the reinfection risk and how can we have effective prevention programs to take care of people that haven't yet received treatment, to have a strategy to avoid infections, reinfections, and to avoid or reduce damages. We want to work with the indigenous population, the Afro-Mexican populations that are in different states. We believe that this is paramount. We need to understand why there's hepatitis C in these regions. And we also have a national observatory from the beginning of the strategy, and our plan was made up through the collaboration of different institutions. We meet every 15 days to understand what is being done in the different states, what can we improve, and in this national observatory, we have the participation of community leaders, the different health institutes, the national strategy for the prevention of addictions, the DGE, DGIS, DGTI, DGCES, CNTS, DGPPS, DGEGYSR, different leaders at the clinics, the different members of the academy, and PAHO. We have a group, a task force that aims at the reduction of damage that is working with specific populations. This is what we believe, and we are convinced that we need to work together. Coordination, inclusion of the different actors is paramount because it will allow us to move towards the elimination of hepatitis in the country. Thank you.
Bueno, Alexe, muchísimas gracias por tu...
Thank you so much, Alex, for your presentation. I am encouraged to see how many progress you've made in Mexico, because we are running out of time and we're lagging behind. We will move right ahead to the next presentation. And please check the chat because there are some questions for you. Could you please just respond to them? And let us move on directly to the next conference. So this will be about Brazil. Dr. Karen Tony. It says Karen Tony, but he said Cristina Ferreira.
Con Dr. Karen Tonini.
It is Dr. Karen Tonini, not Cristina. She is the directress of the National Hepatitis Program in Brazil.
Para un asistencialista como yo es un desafío poder ver como un programa como el SUS, ¿no?
We want to learn more about the SOS program and compare it to other programs such as the one in Mexico. Mexico's health system is similar to the one in Argentina. And so we want to learn from all of the different programs in the different regions, in the different countries. So we need to look at each other, at what we're doing, so that we can set the next steps towards elimination of hepatitis.
Obrigada, Dr. Marcelo, pela apresentação. E em nome da doutora Ana Cristina, que é a coordenadora dos programas de hepatite.
On behalf of Dr. Ana Cristina, as Dr. Jason Pereira, who is the director of the department, it's a huge opportunity to be here to speak about our advances and also our challenges. And this is very special for hepatitis C. We were together last July, and the document was published, and we hope to bring this discussion to the area for us to go on with this until 2030. We are going to speak about this policy about viral hepatitis in Brazil, and I would like to mention the Brazil, which has a continental size, is the sixth country in the world, sixth largest in the world, and in territorial area, it's huge, it's the first largest in the world, and has so many differences. It needs one look for each territory and brings us a complexity when we speak about the management of the health system. We have to suggest public policies to face the challenges, health policies to be adapted and applicable in a country in the size of Brazil. And before mentioning the hepatitis C, I would like to mention our unified health system, because we are proud of it. And for those who are really very proud of this accomplishment. The unified health system is an accomplishment that our people did. In 1988, in the federal constitution, we had the right to health. So as managers, we have to think about public policies to guarantee our right to health. In 1990, we had the organic law based on three pillars: universality, integrality, and equality. These are free services which are free of charge, and people who have access to the system, and those that can be, and we have also a complementary health. But the study in 2019, 71.5% of the Brazilian population depends exclusively on SUS. Speaking about the National Viral Hepatitis Program, next year we'll have 20 years of this program. It was created in 2002. There is a federal normative establishing the responsibility. We have one coordination and 27 state coordinations in each Brazilian state, and every municipality, 5,570 municipal coordinations to fight against hepatitis. For us to work together, we have commissions at the municipal level, state level, and national level, and we can discuss politics, what we call tripartite commissions, to publish the guidelines, to implement strategies to face viral hepatitis in the country. Here, it was very interesting to show you what are the exams, tests, and how can we provide this through we have the medicine tests and other health impacts. We have rapid anti-HCV tests for hepatitis C and hepatitis B. We have conventional viral load and rapid hepatitis B and C tests. We have HCV genotyping. We have also hepatitis B and C medicines through the Ministry of Health, as well as prevention devices like male and female condoms. So have the possibility to negotiate, and we distribute these for all states and territories. In a complementary way, we have some actions through a list with several different values. The Ministry of Health give us values for states and municipalities to complement this and can fund this in their territories through their needed actions. And here we have it's important to see the difference of hepatitis cases in Brazil. We have the South area, and also we have health industry with population, and also they have detection test area, like we have the North area, the Northeast region, and also the index of new cases is largest, not because of the population profile, but this can be influenced by the difficulty of access for diagnosis and treatment as a whole. So from here, we can see that there is a meaningful difference among the areas, and we demand that we have strategies, different strategies when we're speaking about treatments.
Aqui a gente traz pouquinho sobre o nosso plano nacional.
Here you can see the plan. We have an agreement with all those, and from this, they could establish some levels, how diagnosis can be. For example, in 2021, it was established that we have to address more than 15 million people, and we have to treat more than 50 million people to eliminate completely hepatitis by 2030. This was agreed among the three government levels, the federal, state, and municipal level, to follow the evolution of these policies.
E aqui eu trago para vocês
Here,
os protocolos clínicos e diretrizes.
We can see the clinical protocols. These documents, they orient all prevention with hepatitis, and they should determine for this, and when you speak about treating people, the first protocol that started to see some was in 2015, but because of the price we had concerning the drugs we had and the impact we had, this protocol would prioritize for people in advanced phases. So we could insert the drugs, and we had to limit this for those who were in some advanced phases. In 2016, we had the registry of new drugs. In 2017, we had the 3D with a new protocol version. In 2018, they had the universality of the treatment, so they could have an impact concerning drugs to do this universally, allowing the treatment for all people, independent from the...
Em 2019, a gente mudou a estratégia de aquisição de...
And we changed the strategy, we changed the drugs, and we should do the result of this, as the majority of them, we started to buy drugs using the same therapy, And for those that had the least impact on the system was the vendor and the provider to Brazil.
E essa mudança na maneira de aquisição, permitindo uma
This
concorrência
change
trouxe um resultado muito importante para o sistema de saúde, porque garantiu a sustentabilidade do programa e do
This
fornecimento
is the sustainability,
pela diminuição de preços. A gente teve, então, a primeira compra de
the first buy
em 2015 e 2016 também, com custos que chegavam próximo aos 11 mil dólares, custos médios de tratamento próximo aos 11 mil dólares. Esse custo reduziu
this
um pouco
cost was reduced
3D no Sistema Único de Saúde. Em 2018, nós tivemos a
in
inserção de
2018.
que ampliou a concorrência e trouxe também um benefício para o Sistema Único de Saúde. E quando a gente mudou de vez a forma de
And when it changed
aquisição dos medicamentos, fazendo a concorrência pelo
to acquire drugs concerning the therapeutic results,
32 dólares por tratamento completo. Esse valor de 2019 ele teve um incremento porque nós precisamos naquele mesmo
we
ano
had the increment,
de glecaprevir com pibrentasvir, que naquele momento era o único medicamento indicado para tratar pacientes com doença renal
and this is for those who had chronic kidney disease.
Nesse slide a gente coloca
In
a
this slide, we can have the historical.
Então, desde 2010, quando as alternativas terapêuticas ainda eram interferon, ribavirina, buciprevir, telaprevir, e 2015, quando o SUS passou a fornecer os DAAs. Então, nos anos de 2020 e 2021, a gente vê uma queda.
In 2020, 2021, we had a drop. We had the pandemic's impacts. People didn't go to hospitals, and the system was dedicated to combat the pandemics. So we are now trying to, it's hard, it needs a gigantic move to look for these patients again. So we are in this process to have the strength we had in 2019 to improve the situation. Concerning our goal, concerning the elimination target for this, we have less treatments, and the goal is to increase the need for new strategies to treat these patients.
Então, em relação à meta de 2030, nós já cumprimos 25%.
Concerning the 2030 goal, we are in 24% of the number of treatments we should perform. We are 1 and 5 months behind. So we have a larger demand to eliminate hepatitis in Brazil.
Aqui eu trago a estimativa de casos de hepatite.
Here we can see the estimate of hepatitis C. We have the prevalence and treatment. We can see the from 15 years old to 9 years.
Para a população geral, a gente tem uma prevalência de 0,5% e HCV, uma prevalência de HCV.
And we have also a HCV of 32%. This, we have been treating 140,000 people with this slide shows us an important vision since 2016, how they were inserted, and we had a decrease in the number of deaths from 2016 to 2019. And this is very important when we have innovation and to reach the goals concerning elimination. Here we can see the reported cases of hepatitis A, B, C, and D. For hepatitis C, we had a reduction of 33%, and this replicated for all hepatitis, and this shows the dimension of this COVID impact and how we can think and rethink, review our goals, review our mathematical models for us to have this and to go on with our goal until 2030. I know that here our focus is hepatitis C, but the vertical transmission, we have to have a different look concerning the, for hepatitis B, we have vaccinations, drugs, prophylaxis that contribute to the decrease of these cases. And in Brazil, we have the indication that this is the universal testing for pregnant women with hepatitis B and C. For us, in the opportune moment for hepatitis C, we cannot treat pregnant women and newborn babies. We have to follow up these women and also the newborn babies. And in Brazil, we have to advance with this. And the goal is to eliminate. And now I have some projects that we are trying to implement. The oral fluid test to test hepatitis C. Our intention is to test this in different populations, São Paulo state. Our intention to test people that drug and alcohol psychosocial care center. In Pará, we intend to help the riverside communities and also giving training to the health professionals, and also Rio Grande do Sul. Our intention is to test the strategy for people in prisons, and here in Federal District, it's to improve the primary care services and to develop and apply vaccination for this population that don't receive primary care services. And also for hepatitis elimination, we have the NGO's public notice, hepatitis C microelimination in dialysis services. And those that are in people that, and also strengthening the role of nurses in viral hepatitis elimination to improve the diagnosis and the treatment of viral hepatitis. Thinking about this, the strategy in Brazil to improve the diagnosis is decentralizing to primary care. We have some centralized cases, hepatitis C. Really, we have a work and we have a line of care to guide the care of people with hepatitis B or C in primary health care. And when one identify these people, we have to guide the care of these people. We will publish this line of care and include it in our primary health care, and also invest in the training of health professionals, nurses, physicians, health professionals in general. this capacity building to qualify primary care health workers in the care of viral hepatitis and nurses in viral hepatitis care. Here, we can see the strategies in development. We have to qualify non-specialist professionals with a focus on nurses and physicians. We have also the agreements between management levels for the implementation of strategies for the elimination of viral hepatitis, enable the use of modern objectives, simplify technologies and protocols focused on expanding comprehensive care, mobilize actors from medical and civil societies, universities, and managers to implement actions to combat hepatitis, and the establishment of actions in partnerships with the PNI for strategies to increase the vaccine coverage for the hepatitis B vaccine with actions aimed at different age groups. Thank you very much.
Muchísimas gracias.
Thank you so much, Doctor, for your great presentation. I don't believe we have any time for questions, but we encourage everyone to leave their questions on the chat where we will be taking care of them. We are now going to hear from Dr. Cielo Janet Rios. She is the specialist on ITS, HIV and hepatitis. She works in the direction of prevention of hepatitis in Colombia. Doctor, thank you for your presentation. Go ahead. Thank you so much for the invitation to join the coalition. I think you can see my screen, right? Okay. What do we need to move towards the elimination of hepatitis in Colombia? First of all, let us understand the charge of this disease, hepatitis C and B in Colombia. We had two different inversion cases of hepatitis C and B in Colombia. On the left, we can see the inversion of 2017, and where we see that the prevalence is 0.66 with an estimated cases of 325,000. We did the same exercise for hepatitis C on 2019. The prevalence was 73.73% for all age groups. But we believe that people under 24 years of age is lower than 24%, and it could reach 1.5, 1.6% in people from 50 years of age and onwards. And this was thanks to the vaccination program that has been implemented in Colombia for more than 25 years. The number of deaths from hepatitis C and B because of hepatic cancer, cirrhosis, and etc. We believe that there is 25% of deaths that could be linked to these two different events. But we see that it has been stable throughout the years when we compare to the total deaths that we have from cirrhosis and hepatitis in general. Regarding the notification of cases, Colombia has a registry. We have a compulsory notification for hepatitis B, C, and D. Also for hepatitis A, but I'm not putting the statistics here. For hepatitis B, for instance, from 20 to 2020, you can see that we have a lot of fluctuations. Some of them has to be with the reduction of cases, but in the last years, we see these trends downwards. Of course, 2020 was a year where, because of the pandemic, we didn't have so many cases. Regarding hepatitis C, we had an increasing but stable curve. And then from we started the centralized process, we see how cases increase. And that doesn't necessarily mean that these are new cases. Some of them from the beginning were people that already were diagnosed, but they hadn't been notified. We can see how this is increased, and then we see a reduction in 2020. With the different exercises that we've carried out, we believe that we have a 9% prevalence of people of hepatitis B and 13% for hepatitis C. Regarding treatment, we carried out an exercise in 2019 where we identified 21,000 people, and 4.8% were receiving treatment back then. Remember that not all patients with hepatitis B need treatment. And then this is the group of people that were co-infected with HIV. We had identified 4,000 people, 648, and 40.2% are infected or co-infected. And what we had to do is to strengthen our strategy for this population. This is information on chronic hepatitis C. From the centralized purchase of drugs, we established as well an information system that would allow us to follow up people with hepatitis C. And we've observed that at least from 2019 to 2020, we see women that are diagnosed, women that are diagnosed at over 59 years old, whereas young people from 25 years old have an early detection, and a peak between 30 to 35 years. And this is where we have a lot of men that have been diagnosed with hepatitis C. The explanations are the following, that this group is the one that has been receiving more triage, and because we have a concentrated pandemic, a big portion of people are men that have sex with men, and that's how we believe that we have this transmission. And probably from this age group, this is people that use drugs and they inject drugs. From the centralized purchase of drugs, we see that there is a number of cases that have a diagnosis under a year. We see an increase. In 2019, it was 63%, and in 2021, on up to June 2021, we had 77.7%. So we are improving our early detection of people, and they are receiving treatment earlier on. So this is a great progress. So from the centralized purchase in 2017, we have a registry of the total people enrolled. This is the information system that are having treatment. We record more than 7,000 people, and from there, 2,422 have received treatment. That is 86.7% of people enrolled in the program, and they were enrolled because they were already receiving treatment. To the right, we have the sustained viral response and how we are having a similar response through medication, with 97% for patients that are receiving treatment from the centralized purchase. So those patients that do not benefit from the centralized purchase are very few, because most of the patients are patients that have had hepatic problems that were significant. Most of the patients fall within the treatments that are offered through the centralized purchase, which is 2,225, which is 91% of patients that are receiving treatment. This is a very complex table, just highlighting that for hepatitis B, the risk factors are people that have several sexual partners, and for instance, men that have sex with men, people that say that their partner has hepatitis B. And with that, we reinforce the theory of sexual transmission. And these are the different risk factors per population. So we have people that have multiple sex partners, and people that use drugs and inject drugs, which is 5.7%. And like I was saying, men that have same sex with men, which is 25.7%. This is the percentage of people that have hepatitis B positive tests and that have received a liver transplant. As cases increase, we see an increase in the people that have been identified with hepatitis B, but it has been stable for the last year with a trend for a reduction. And for hepatitis C, we see that this is a significant number from 2015 to 2018. And since 2019, we see a slow decrease. We're not able to say if this is because of the treatment, but the numbers are encouraging. Talking about cost, the black line is the baseline. So we believe that every year, hepatitis B costs around 400,000, 370 million pesos, which would be $121 million. And for hepatitis B, it would be $278 million USD. Vis-a-vis the total of population. And we did this so that we can design some elimination programs. So since 2014, we have created a national plan for the control of viral hepatitis. This is a program that went from 2014 to 2017. And in 2018, we unified our plan, and we call it the National Plan for the Response to ITS, HIV, TB, and hepatitis B and C. And this is a plan that goes from 2018 to 2021. On this same period of time, in 2016, we issued the first guidelines for the clinical practice on diagnosis and treatment of hepatitis B. We did the same for hepatitis C. This guideline was updated, and we have a guideline for treatment based on the OMS, WHO recommendations and PAHO recommendations. And then we have this strategy for the elimination of the transmission of HIV from mother to child. And this is a plan that goes from 2019 to 2030. Centralized purchase of drugs for hepatitis C began in 2017. By 2021, we've already bought more than 1,000 treatments. This is the total treatments from 2017 to 2021, and we've been able to save $450 million pesos, which is about 147 million USD. And we've saved money because in 2016, we believe that the cost per patient was around 32,000 USD, and the cost has been reduced by 2021, which is a total for people, for each person is around 4,000 USD. We have a treatment available, and the percentage of coverage, the health insurance of Colombians is 98.7. So treatment is available for almost all of the patients. There is just a few people that do not have insurance. And we talk about Colombians because migrants that have received papers in Colombia are also receiving treatment. And for the other people that are migrants and do not have papers, they are not registered by the system. We've also made toolkits for the community work on hepatitis. So these are some screenshots of a strategy that we've developed to educate on the prevention of transmission. And below you see, for instance, the cover, the poster for education on pregnant women. We've also covered vulnerable population for vaccination. We work specifically with men that have sex with men, the transgender women, the sexual worker, the people that you inject drugs, and people that live on the street. By 2021, vaccination is available for all these 5 different groups of people. COVID has made it more difficult for us to continue vaccination, but the program goes on. We have an EMO vigilance system from the National Health Institute. So we have the report of donors. And so when somebody goes and donates blood, they can find out directly if they are positive for hepatitis. From the centralized purchase system, we've strengthened the information system. Civigila, which is this form over here, which is the compulsory reporting system when we identify a case of hepatitis. Then we have a follow-up of patients, RIPS, where we report treatments and tests, and MIPRES, which is the system that allows distribution of drugs. I would like to talk about the priority, the first activities or the activities that are a priority for us. So triage for HIV, hepatitis B, hepatitis C with vulnerable populations. And we also have the promotion, the maintenance of health route, which is something that is aimed at all Colombians, and we have different age groups, and we do a rapid test for people that are at higher risk. Specifically for hepatitis C, people over 50 years needs to receive one test so that we are aware of infections. People that use drugs as well, and other criteria that are described in this technical guide. This is a table that shows how in the recent years we've increased triage compared to when we see 2017, 18, 19, we see that there has been a change in the percentage of 20.2, and on 28 to 2019, we've had a change in the percentage as well. And we see how we've also increased the use of rapid tests and the lab tests. Through this decree, we include different profiles for the rapid test of HIV, hepatitis B, and C. We are right now carrying out the HIV, syphilis, BHB, and BHC rapid test. This is the amount of samples that we've taken. And of course, we use the International Day of Hepatitis Awareness to carry out education for the community. These are some of the samples that we did for some of the materials that we prepared for last year. And we've also developed a specific course for general practitioners and other healthcare professionals. And we are working with PAHO to have this primary care attention for hepatitis B and C. As you can see, we always try to coordinate the different activities. What have been the different challenges to increase detection? Well, the lack of information in the community, lack of knowledge of the algorithms, that not a lot of the tests are available. The competence on the priorities of public health, and etc. COVID has also affected our work. There were some delays on the tests, the follow-up that were needed to receive treatment. And even though we carried out our program, we were able as well to have telemedicine meetings.
Los mensajes clave, por favor.
Doctor, could you just move right away to the key messages?
Sí, para cerrar, básicamente, pues...
Debiéramos ir cerrando, Cielo, para dejarle tiempo a los panelistas.
We need to conclude, Cielo. I'm working on that. These are the different scenarios. And then we still need to work on triage to achieve reduction of the costs, simplify attention specifically for vulnerable populations, to have prescription by the family doctors, and to do the different adjustments that are needed to achieve the goal. Thank you. If you have any questions, please leave your questions on the chat so that we can respond to them. Thank you for the presentation. And we are now moving on to the panelist section. We have Leandro Sereno from PAHO, who is leader of the HIV unit, TB, hepatitis, and other sexual transmissible infections. He will talk about the need of detection in Latin America. I'm going to share my screen, and I have a few slides that I would like to show you to talk about the different activities that we're carrying out. I want to thank the invitation of the coalition. Dr. Ruben Mallorca was the person that was invited for this session, but he was unable to attend this meeting because he had to take care of some urgent matters. And I am the regional lead for the Americas in Washington. And so I want to talk about some of the activities that we're working on. We published at the beginning of this year the Global Progress Report on HIV viral hepatitis and sexually transmitted infections. We updated figures and different status of hepatitis B and C in our region. And we see that the figures are steady. We've been able to make some progress on the strategic information. We created and generated information to estimate the charge of the disease. Hepatitis C, we have almost 5 million of infections or people that live with chronic HCV infection, and we have 5.4 million of people with chronic infection. And around 10,000 new chronic infection and 23,000 hepatitis B deaths. This is the coverage in the region, something that we also publish in this report. We have the 18% of diagnosis in the region. 20% of people have been diagnosed with hepatitis. This could be a subestimation because we've been able to identify people that wanted to donate blood, and we were able to identify them as hepatitis patients. But sometimes a diagnosis doesn't mean that they're receiving care. We need to take care of this matter. And this is treatment as well. For hepatitis B, as you can see, is only 3%. And for hepatitis C, we have 22% of coverage because of the progress made by the US and Canada and some other countries that have been advancing in treatment. We can mention Colombia and Mexico. We've also working on the strengthening of mortality data. We've published this guide to help countries to estimate the mortality rate in their countries. Mortality is one of the indicators that defines the elimination of hepatitis. We've seen many countries having some issues in reporting these indicators. And with this protocol, we aim at supporting people to have an estimation of the proportion of HBV and HCV infections in patients with cirrhosis and HCC. We also want to strengthen the surveillance system and detect failures in the coding. For instance, people that died of cancer do not have a diagnosis of hepatitis in their death certificate. So we want to improve this, enhance this information. We also have the public health and economic impact of hepatitis elimination. We also did in the investment case for hepatitis B and C. We carried out some inversion studies. Mexico, Brazil, Colombia, Chile, Peru, and Ecuador, who have concluded their analysis. And I think that this information will be very important to move towards the elimination. So these are the figures from these different countries. Peru and Ecuador are concluding their analysis. And we are working on other countries because they've expressed their interest on doing these inversion studies, but because of the pandemic, we haven't been able to move forward with that. We also have specific activities on the Andean region. We have a project that is called the Andean Hepatitis Elimination Project that aims at supporting the national responses. The purpose is to support countries of the Andean region to accelerate the response to viral hepatitis. This project has received an award, and we also have the support of PAHO in the implementation of this project on the countries of the region. The contest is because we want to build on and strengthen the agreement established by the Declaration of Santiago on hepatitis. We had a meeting on 2019. Chile convened the different leaders in the Andean region, and they agreed on signing an agreement, and so that we can have this project. And the project is the result of the agreement, and it works on advocacy and awareness, national hepatitis policies and planning, and the access to diagnosis and treatment. This is a very ambitious plan with the participation of different actors and partners, with the support of PAHO and the support of specialists that are also taking part in this program. And as part of the access to diagnosis and treatment, we have the PAHO strategic fund. So for the different health minister, there are some price negotiation on long-term agreements with providers, medicines and diagnostics, and a constant review of eligible products and support demand estimation. You can see some of the costs here, and you can see how some of these awards are available for some of the countries. Patents are a limitation or a barrier, and so we sometimes need to use original drugs instead of generic drugs. For instance, sofosbuvir. But if we don't have these limitations, then we can spend $9 for complete treatments of hepatitis. And then we have the support of the PAHO award to reinforce the purchase of the different drugs. Very quickly, we have published the framework for elimination guidance for country validation of viral hepatitis elimination. We talk about the different strategies, tools. We are reviewing this report. We are going to carry out the pilot project in Brazil, just to make sure that the criteria work. And this guide includes the absolute targets, because we're no longer talking about the reduction, but we also want to talk about the absolute targets that each country has to achieve. And this is important because for some countries it is difficult to define the target. And so we believe that absolute targets will get rid of the situation. And just to close, we want to talk about the elimination initiative. It is a both pathway forward. It is a framework from all of the members that so viral hepatitis elimination is within a broader elimination agenda of ending a range of communicable diseases and related conditions in the region. It builds on several achievements of the region of the Americas. We share experiences, we share resources where we can enrich our knowledge. We have links over 30 global and regional strategies and plan of actions into one structure and unifying framework, and it provides also the framework for the attainment of the 2030 Sustainable Development Goals and the health agenda for the Americas. We use a patient-centered method. Thank you. Dr. Solange is now going to present. She is the co-founder and vice president Sorry, she is the leader of the National Program of Transplant. You have the floor. Thank you for the invitation. So we wanted to talk about the situation in Uruguay. Uruguay is a very small country. We have a total population of 3,474,000. The prevalence is 0.7. We believe that 24,000 people are infected, but we do not have prevalence studies. The incidence of the notification is 391 cases in 2019 and 237 cases in 2020. We know that the compulsory reports since the pandemic they failed. We do not have information on mortality by cirrhosis, but we also have information on transplant and we have some information on cirrhosis. We have a integral health system in Uruguay. And for serology, we have PCR, which is compulsory in some of the countries, $70 USD, and the quantitative is 135 US and the genotype is 160 US. We have a national fund for resources for the general purchase of drugs. From 138 treatments, only 114 were approved, and in 2020, 105 out of 136 treatments were approved. The patient has to pay for the PCR test, and that's why we don't know how many people have been healed from the disease. We have a universal coverage in Uruguay, and in 2017, we had the introduction of antiviral treatment, and we started using also genetic treatments. We do not have a genotype since 2020. We do a APRI, and we continue with the determination of the viral load. Some people do not respond to the question sometimes. We see new infections since from 2015 to 2020. It seems that there is a decrease. We believe that there is a decrease because of the pandemic, but we see that there is a plateau on the patients that need transplant. We worked on the policies for the elimination of hepatitis C with the Ministry of Health, the ITS HIV/AIDS program, and the National Committee for Public Health. We published a first national guide on how to manage viral hepatitis B and C on the different care systems and the attention. We have the participation of technical equipment from the national program and UDELAR. This is the universal test is compulsory for people over 40 years of age. We have a PPL test. We are also moving towards a test for the pregnant women. And we are planning on having FibroCan, and that this is covered by institution and not patients. Next slide, please. What are the different challenges and strategy for the elimination of hepatitis C in Uruguay? We need to overcome the gap to develop a national program for viral hepatitis. We're always grateful for knowing experiences in other countries. We need to strengthen strategic information, and from that, we are also working. We're seeing if with the support of HIT, we can start having the support from authorities to identify patients and to guarantee access to treatments. So with a little bit of luck, we'll be able to move forward. We had a partial support that would allow us to move forward. Thank you. Thank you, Doctor. Marcelo, you have the floor. Thank you, Solange. We are going to ask Dr. Patricia from the World Hepatitis Association to give her presentation. Thank you so much, Marcelo. Good morning to all of you, and thank you for the coalition for the invitation to be able to share some of the experiences with you and perhaps to strengthen the exchange of information. I want to congratulate the work on the different countries. I am pleased to see what has been done in Mexico, Brazil, and Colombia that are moving forward, and hopefully we'll be able to catch up with them one day. We are working towards the elimination. We're lagging a little bit behind, but we're moving forward nevertheless. These are the main achievements for Guatemala. These are important milestones, even though we haven't reached elimination. We are able to do 100% of the triage when people are donating blood. And the only thing that we haven't been able to achieve is to have all donors to be volunteers. We only have 5% of volunteers, the rest are preposition donors. And since 2004, we do a triage. I am sorry, but I have another meeting. I was told that this meeting was going to last an hour and 30 minutes, and we are on 1 hour and 40 minutes. So I'm going to have to hang up because I have to go to another meeting. Apologies. Spanish into English translation won't be available now. Thank you so much.
Se realizan sin costo, porque ya el Estado ha adquirido pruebas para tamizaje y para diagnóstico. La guía de atención integral ya se elaboró en tiempos de pandemia. Ese es un logro muy importante y una felicitación al Ministerio de Salud por haber hecho ese esfuerzo aún en tiempos de pandemia. Está pendiente de que se implemente porque recién se publicó este año, se publicó online y están haciéndose los lineamientos para la implementación y la capacitación para los servicios para que la implementen. La sociedad civil ha participado en la mesa técnica desde el inicio, desde la formación de la mesa técnica, que fue en 2017. Entonces sí hemos tenido como sociedad civil voz en esta situación. Y la academia también ha participado en la formación para diagnóstico y tratamiento de hepatitis C ya la academia, la Universidad de San Carlos, que es la única universidad estatal, ha llevado a cabo 2 cursos. Un curso sobre hepatitis C para todos los profesionales de salud del Ministerio de Salud y del Seguro Social y de Previsión Militar, que tenían que ver con lo que era la planificación y todas las acciones para hepatitis. Y luego en el 2019 un curso de diagnóstico y tratamiento de hepatitis C para profesionales de atención primaria. El primer curso fue presencial y el segundo e-learning. La siguiente, por favor. Otro logro muy importante es que desde el primer Día Mundial de la Hepatitis hemos participado en la conmemoración, haciendo promoción, ¿sí?, para la hepatitis, y en el 2018 logramos conmemorar ese Día Mundial todos los sectores interesados. Está el Ministerio de Salud, está OPS, está la Universidad de San Carlos, el Colegio de Médicos y Cirujanos y la sociedad civil. Entonces ese es un momento muy importante, el Día Mundial, para levantar la conciencia, ¿verdad?, para la eliminación de las hepatitis. La siguiente, por favor. La guía de atención, todavía no tenemos nosotros en Guatemala un plan nacional de hepatitis, pero tener una guía es un logro muy importante, porque esta guía, en primer lugar, fue hecha de manera participativa. Aquí podemos ver nosotros que además del Ministerio de Salud, que fue el rector de esto y es el responsable, se tuvo a Sanidad Militar participando en esto, se tuvo también a lo que es gobernación para lo de prisiones, ¿verdad?, para los prisioneros, la Universidad de San Carlos como academia, la Asociación de Gastroenterología como especialistas y la Asociación de Ginecobstetricia, la Asociación Guatemalteca del Hígado y la Alianza Mundial de la Hepatitis como sociedad civil, OPS e INCAP como organismos técnicos internacionales y también AHF. Esa guía habla de prevención, diagnóstico, tratamiento y seguimiento en todos los ciclos de vida. Como tal están las guías de atención en el Ministerio de Salud. Entonces, son el primer paso para que se implemente tamizaje y diagnóstico a nivel nacional. Siguiente, por favor. Los objetivos de Guatemala están plasmados en esa guía porque, como les conté, todavía no tenemos un plan nacional de hepatitis, pero están, ¿cómo se dice?, en congruencia con lo que es la Estrategia Mundial de Eliminación de Hepatitis. Los indicadores de evaluación de la guía están al 90%. 90% de las personas que tienen algún factor de riesgo han sido tamizadas, y de las tamizadas al 90% se les realiza el diagnóstico, y el 90% de diagnosticadas reciben tratamiento con antivirales de acción directa. Y se espera que la respuesta al tratamiento sea mayor del 95%. Estos son los indicadores de evaluación que tiene la guía. Y me imagino que van a ser los objetivos o las metas de Guatemala en el futuro. La siguiente, por favor. Gracias. La capacidad para diagnóstico. Este es el mapa de Guatemala. En todo el territorio nacional, ¿sí?, se ha establecido la capacidad para hacer pruebas rápidas, para tamizaje. Y para hacer diagnóstico con carga viral, tenemos el Laboratorio Nacional de Referencia, que está situado en la capital, y 16 unidades de atención integral, que se llaman UAI, que son las unidades de VIH, donde se atiende VIH y que ya tienen el aparato GeneXpert para hacer carga viral. 2 hospitales nacionales que son UAI cuestan con COVAS, pero esa capacidad instalada de las UAI para VIH es la que se ha utilizado para tener capacidad de diagnóstico de hepatitis C. El único problema es que las UAI están en el tercer nivel de atención. Aunque tenemos 16 UAI en todo el territorio, aquí las tengo marcadas. Sí, hay partes del territorio donde necesitamos esa capacidad diagnóstica y no la tenemos, ¿verdad? Entonces tenemos 16 UAI, 2 están en la capital, pero son todas en los hospitales. No tenemos ninguna en segundo nivel ni en primer nivel de atención. Y otro problema que tenemos, si la siguiente, por favor. La siguiente es que ahorita no hay reactivos para carga viral en las UAI. Como no hay reactivos para hacer carga viral, no hay diagnóstico a nivel de la República y tampoco hay demanda local para tratamiento porque no hay casos diagnosticados. Por favor, la siguiente, para que me aparezca. Ahí estamos. Entonces, como no hay reactivos a nivel local, se deriva a un nivel superior, que en este caso son 2 hospitales que están situados en la capital de Guatemala. Y esos 2 hospitales son los únicos que por el momento tienen reactivo para carga viral y tienen tratamiento. El Hospital Roosevelt, que es una UAI muy grande, ha comprado tratamiento para 1 año. De manera que el Ministerio de Salud no puede comprar tratamiento si ya lo tiene una unidad. El problema es para los pacientes que tienen que transportarse bajo su costo hacia la ciudad capital para recibir tratamiento. Entonces, el acceso ahí se ve limitado, ¿verdad? Sigamos, por favor. Sin embargo, tenemos algún avance. Se empezó en enero de este año a hacer ya el tamizaje en las UAI, en todos los servicios, el tamizaje de hepatitis B y C. De hepatitis B se hacía embarazadas antes, ¿sí? Pero el de hepatitis C se empezó a hacer este año ya porque se contó ya con un instrumento de reporte, el CIGSA 1.2, y entonces tenemos que de enero a agosto 2021, en todas los que han reportado al CIGSA 1.2, ¿sí? Se han hecho pruebas de VIH, de hepatitis B y de hepatitis C. Sin embargo, como ustedes pueden ver acá, nos falta en hepatitis C, ¿sí? Nos falta mucho en hepatitis C, a pesar de que se provee de pruebas, pero tampoco se compra la misma cantidad de pruebas que VIH. No todos los hospitales reportan, o sea, los servicios de salud del primer y segundo nivel reportan al sistema, pero los hospitales no reportan. Hay una falta de gobernanza acá. Por lo menos este año ya empezó a reportar el Hospital Roosevelt, que era un hospital que tampoco reportaba. Tampoco se ha establecido vigilancia epidemiológica a nivel nacional y se aduce que es por falta de recurso para contratar personal que lleve a cabo el programa de vigilancia epidemiológica. Entonces, eso es algo que tenemos todavía que hacer. Se hace vigilancia nada más de la vigilancia de VIH, ¿verdad? Y en embarazadas. Digamos la siguiente, por favor. Entonces, este retraso que vemos, o rezago de pruebas de hepatitis C, también lo vemos en las embarazadas. En las embarazadas se hizo casi 1000 pruebas menos de hepatitis, de VIH que de hepatitis B, pero en general el 53% de las embarazadas han sido tamizadas, pero solo el 24% ha sido tamizada para hepatitis C. Lo bueno es que ya tenemos establecido el tamizaje de hepatitis C y que muchos países del mundo todavía no lo tienen, ¿verdad? Estados Unidos ya el CDC lo estableció, pero falta en muchos países. Nosotros por lo menos ya tenemos eso, solo falta tener más pruebas y la capacitación y la concienciación, ¿verdad? Para que se hagan las pruebas. La siguiente, por favor. Ahora bien, los efectos de la COVID-19 es que los recursos humanos han sido llevados a hacer otros trabajos y a fortalecer la respuesta de COVID-19. Entonces, se tienen que dividir y ya no hay tiempo, ¿verdad? Hace falta recursos humanos para promover lo de hepatitis. Recursos financieros siempre hemos tenido dificultad, pero ahora con COVID tenemos menos recursos financieros. Es más lento, todos los procesos ahora son más lentos, cuesta reunirse con las personas porque tienen otras actividades respecto del COVID, ¿no? Que tienen que ir a suplir esto. Y la accesibilidad a los servicios se ha visto mermada. Muchos servicios de consulta externa han cerrado, ¿sí? Ya solo hay de emergencias. Entonces, la gente no tiene atención para casos agudos de hepatitis, ¿sí? Los casos crónicos de hepatitis crónica o de cirrosis tampoco están siendo atendidos como debe ser. Y, por ejemplo, tenemos una compra de un fibroscan para un hospital nacional, lo compró un servicio de gastroenterología, pero no tienen consulta externa, nada más que para sus casos ya desde antes, entonces no se está utilizando como debería ser. Tenemos entonces búsqueda activa de casos disminuida, igual también la vacunación está disminuida, y dificultad para campañas de concientización, porque los recursos están destinados, la mayoría, a COVID. Entonces, tenemos esas dificultades, aunque estamos ya abierta la puerta para lo de hepatitis, tenemos todavía mucho que hacer, ¿verdad? Siguiente, por favor. ¿Qué nos falta? Bueno, primero, implementar la guía, ¿verdad? ¿Para qué? Para tener insumos, para poder proveer con más insumos a todos los servicios, porque la guía de atención integral dice que todos los servicios deben hacer tamizaje, ¿sí? Y diagnóstico, los servicios del segundo nivel, o por lo menos en estas guay que les presenté. Nos falta entonces hacer que las pruebas y el tratamiento sean más accesibles, porque como les dije, están limitadas a ciertos servicios, y si ya tenemos implementada la guía, nos va a permitir monitorear el avance de lo que estamos haciendo e identificar brechas y puntos de mejora en este programa, ¿verdad? De hepatitis. Por supuesto que tenemos que hacer un plan nacional de eliminación, pero con la guía ya tenemos bastante. Ya es el sistema del Ministerio de Salud, es el que define qué hace primero, ¿verdad? Ellos definieron primero hacer la guía. Otra cosa es que el Seguro Social, que siempre dio tratamiento con interferón y con otros medicamentos a las personas con hepatitis, cuando el ministerio no tenía esos tratamientos, ahora el Seguro Social no tiene tratamientos. Los pacientes del Seguro Social tienen que ir al Ministerio de Salud a recibir tratamiento porque el Seguro Social no ha comprado los tratamientos. Entonces ahí también habría que mejorar eso. Y luego, capacitar a todos los trabajadores de atención primaria para diagnóstico y tratamiento de casos no complicados, para que no tengan que ir al tercer nivel de atención las personas, que les va a costar de su bolsillo gastar en transporte, en hospedaje, en comida. Y somos un país que está con bajos ingresos económicos, ¿verdad? Y un país muy inequitativo, que necesita ayudar a esa cobertura universal de salud. Se necesita hacer vigilancia epidemiológica para tener un panorama, ¿sí?, más real de la situación y poder pues solicitar el financiamiento que se necesita para las hepatitis. Y se necesita hacer promoción para que surja más demanda de pruebas y de tratamiento por los sectores de la población afectados. Entonces, sí hemos avanzado. Yo, como sociedad civil que tiene 20 años de trabajar en esto y de estar promoviendo, considero que ya lo que tenemos es bastante. Sobre todo que tenemos tratamiento gratis para todas las personas del país, independientemente de su condición social o si están asegurados por el Seguro Social o no, e independientemente de su grado de avance de la enfermedad hepática. Entonces, eso es muy importante. Y que tenemos diagnóstico y tratamiento sin costo también, pero las personas deben acceder a los servicios. Así es que me parece que, pues bueno, en tiempos de COVID hemos logrado algo también y ahí vamos caminando y esperamos ver qué hacemos para que podamos lograr la meta de frenar la transmisión y que las personas tengan diagnóstico, tratamiento que sean efectivos, ¿verdad? Y que todos tengan acceso a eso. En la siguiente, muchas gracias a todos por su atención. Este es mi correo electrónico por cualquier duda. Gracias.
Muchísimas gracias, Patricia. Brillante presentación. Vamos a darle paso ahora a María Eugenia de Feo o Moyano, quien es la presidente de la Fundación Hepatitis C Sin Fronteras de la Argentina. María Eugenia.
Ahora sí. Estás muteado, siempre es el temita en los de Zoom. Bueno, ¿me escuchan bien? Perfecto.
Perfecto.
Bien, muchísimas gracias por esta invitación a la coalición, en especial me honra especialmente dado que represento a la sociedad civil de pacientes de mi país, Argentina, y con trabajo hace 20 años, entonces, en el tema de las hepatitis virales. Por lo tanto, me da mucho gusto poder presentar los avances que hemos visto desde la comunidad de pacientes en nuestro país, porque realmente son las vivencias, además de lo que puedan llegar a ser las estadísticas que se presentan desde todos los países, que es realmente maravilloso. Hola. Sí, no sé si se me está escuchando. Sigo adelante. Bien. Realmente ha sido fantástico la presentación de todos los países, lo que estamos viendo en la región.
John, your microphone is open.
Hola, sí. Bueno, yo sigo adelante, ahora sí. Bien, perfecto, ahora se escucha bien. Entonces, en Argentina, lo que podemos decir es que nuestro país tiene un programa para hepatitis virales desde el año 2012, con un comité externo asesor ad honorem, el cual está integrado por la sociedad civil, las sociedades científicas, programas sanitarios, referentes de hospitales federales también. En este programa se busca lograr el control y luego la eliminación de la hepatitis viral. En este contexto se han alcanzado grandes objetivos, como la donación de sangre segura, la implementación de un calendario de vacunación efectivo y una amplia cobertura de acceso al diagnóstico y al tratamiento de las hepatitis virales. Los lineamientos apuntan, por supuesto, a garantizar el acceso a la calidad y la equidad en la atención, como eje central del abordaje de las hepatitis virales. En este sentido, alcanzar la vacunación del 90% en lactantes para hepatitis A y B, concientizar a la población del padecimiento de las hepatitis virales y lograr que al menos el 80% de las personas afectadas sean tratadas y curadas. Este programa realiza, junto al apoyo de la Organización Panamericana de la Salud, en el año 2018 un plan estratégico enfocado de 2018 a 2021. Y este plan estratégico se fundamenta en la información estratégica sobre las hepatitis virales, la prevención de las hepatitis virales y diagnóstico y tratamiento. Ustedes saben que en nuestro país, Argentina, el sistema de salud es fragmentado. Esto quiere decir que una parte de la población se atiende en el sistema público, otra en el privado, otra en la seguridad social, y también existen las obras sociales provinciales. Por eso, como veíamos la diferencia en todos los países en la región, el programa para hepatitis virales en cada lugar tiene que ajustar muchísimas variables. Entonces, las hepatitis virales en Argentina constituyen eventos de notificación obligatoria, según la ley nacional que obliga al personal médico y de laboratorios de vigilancia a realizar la notificación de casos en todo el territorio del país y en todos los subsistemas de salud. De esta forma se han podido obtener datos. Entonces se integran actividades e indicadores relativos a la información estratégica para las hepatitis virales, lo cual se pudo determinar la carga viral que representan en la nación. Entonces, desde ese lugar se publica un boletín epidemiológico específico para hepatitis virales desde el año 2017. Así podemos saber que para las hepatitis A, la tasa por 100.000 habitantes argentina del 2009 al 2019 ha disminuido del 63% al 37%. Esto también está evidenciado en el amplio programa de vacunación que tenemos desde el año 2005, implementado con una sola dosis para los niños al nacer, y también para los niños de 12 meses de edad. La hepatitis B, la tasa se ubica en unos 100.000 habitantes, el 0,4% de prevalencia. Estos son datos del 2019 basados en datos de vigilancia en bancos de sangre. La incorporación de la vacuna de hepatitis B en el calendario de vacunación oficial, desde recién nacidos se ha decidido para que baje esta prevalencia, y desde el año 2012 se ha incorporado la vacunación para adultos, y la vacunación es universal y gratuita. Así alcanzamos en el año 2019 el 82% de cobertura de vacunación con dosis al nacer, cuando la meta de la OMS para el 2020 ha fijado el 50%, y el 86% de vacuna con 3 dosis cuando la meta de la OMS ha alcanzado el 90%. Entonces acá vamos la necesidad de acentuar la vacunación para la población mayor de 20 años. El 60% de las personas que están diagnosticadas para hepatitis B tienen alcance de la cobertura en cuanto a diagnóstico y a tratamiento. El aumento de los testeos ha sido de 857.000 pruebas durante el 2018 a 960.000 pruebas en el año 2019. En cuanto a la hepatitis C, la prevalencia estimada es del 0,5%, lo que redunda en cerca de 220.000 personas afectadas. También, esta es una estimación que también el estudio Polaris ha hecho con el 0,8%, que son 320.000 personas. Se estima que alrededor de 300.000 personas tienen hepatitis C en nuestro país. Como les decía, el 30% cuenta con cobertura pública de salud, y un 70% se encuentra en todos los otros subsistemas de seguridad social y privada. Podemos contar que hubo una disminución en la tasa de incidencia desde el año 2015 al año 2019, cuando se medía en 1,59 cada 100.000 habitantes, y en 1,19 en el año 2019 cada 100.000 habitantes. También hubo una importante disminución vivenciada por las comunidades de pacientes, inclusive disminución de tasa de trasplante y mortalidad para hepatitis C, una disminución significativa en el porcentaje de inclusión en la lista de espera y trasplante hepático. Durante el 2017 se ha universalizado el acceso al tratamiento antiviral. No es necesaria la priorización por estadio de fibrosis. Todos tenemos acceso al tratamiento universal y gratuito. Esto también se ha afianzado gracias al trabajo del Programa Nacional de Hepatitis en la seguridad, en los sistemas de seguridad de obras sociales, seguridad social y seguridad público, que ya a partir de este año se ha reforzado para que tampoco prioricen este estado. Los esfuerzos de eliminación se ven evidenciados también cuando en el 2019 se han alcanzado más de 1.500 personas tratadas en todos los subsistemas de salud. Esto disminuyó durante la pandemia, obviamente, casi al 50%, pero volvió a incrementarse en el 2021 a más del doble, y todavía no hemos cerrado el año. También se ha hecho avances con un programa piloto en las personas con situación de encierro durante el 2015 a 2017, lo cual nos evidencia que hay un 3,3% de prevalencia en esta población, pero nos da una ruta y un camino a seguir para poder fortalecer estrategias y tratar a todas las personas. Las estrategias actuales para la detección de las hepatitis C y las barreras, bueno, se promueve desde el Programa Nacional el cribado universal para hepatitis B y C, en mayores de 18 años y en mujeres gestantes. Esto está actualizado en consensos de las sociedades científicas, del Ministerio de Salud y la participación de la sociedad civil. Acá el desafío es que esto sea adoptado por todo nuestro territorio a lo largo y a lo ancho del país. Las pruebas de test reflejo, como medida de simplificación, es una instancia diagnóstica que se ha implementado con una sólida estrategia en principales hospitales públicos y universitarios de nuestro país, en el cual ha reducido la consulta desde el diagnóstico al tratamiento de 7 a 2 visitas exclusivamente, lo cual eso también nos genera a los pacientes un gran alivio por los traslados correspondientes, etc. Ahora el desafío es que esto llegue a todo el territorio de nuestro país. Por eso la información estratégica es fundamental. También llevamos 2 pruebas pilotos adelante, más con un diagnóstico con gota seca y otra con tarjetas de separación de plasma. Son 2 pruebas piloto que también están enfocadas en este sentido. Las barreras actuales, las que vemos nosotros, los pacientes, la necesidad de la receta médica con indicación de test para hepatitis C. Esto lo estamos trabajando en una ley de la cual voy a hablar en un momentito. Falta de concientización sobre la necesidad de ofrecer el test para hepatitis C en agentes del primer nivel de atención. La provisión continua en todos los establecimientos del país de reactivos para diagnósticos, especialmente en los subsistemas, no tanto en el sistema público, que hay una provisión continua. También algunos copagos que a veces se piden en el subsistema de la seguridad social y privados para el diagnóstico, y fundamentalmente la barrera que tenemos hoy es que tenemos que atravesar, es aumentar la concientización de la necesidad del test en la población general. El impacto que ha tenido el COVID-19 en los esfuerzos de eliminación, obviamente nos ha golpeado como a todos los países. Ha descendido en un 25% la solicitud del testeo, y así también en tratamiento. Sin embargo, trabajamos estrechamente con el Programa Nacional de la Sociedad Civil, buscando revincular a los pacientes que tenían miedo de asistir a los centros de salud y se encontraban con centros de salud cerrados, y la sociedad científica nos ha ayudado mucho con la telemedicina, respondiendo rápidamente a todas nuestras necesidades, a pesar de que los médicos estaban haciendo un esfuerzo titánico en esta pandemia. También los esfuerzos que se han realizado para que podamos resolver todas estas disparidades, como les decía, la ley primera en su tipo en nuestro país, y que esperamos que sea aprobada antes de fin de año, es una ley que integra la situación de salud de las hepatitis virales, la VIH, tuberculosis e enfermedades de transmisión sexual. Y esto va a dar un marco estratégico legal para la atención de las personas con hepatitis virales crónicas. Hoy por hoy contamos un programa de hepatitis virales crónicas, como les decía, pero depende de la voluntad política, la legislación, la ley, en los vaivenes de nuestros países en cuanto a los cambios de gobierno y a las crisis financieras. Este marco legal nos da la garantía del derecho de acceso a tratamiento, a pruebas de diagnóstico, y también las garantías sociales para evitar la carga del estigma y la discriminación. Las estrategias de diagnóstico simplificado, el acceso para tratamiento sin priorización de fibrosis en el sistema de salud, el Plan Nacional de Microeliminación de Diálisis, que es de cobertura del 100% nacional, tengan o no obra social, es otra de las trabajos que se están haciendo para evitar las disparidades. La cobertura sanitaria universal, que nos va a dar este respaldo de eliminar costos en los subsistemas de salud. Necesitamos trabajar más con programas sanitarios, todos los sectores unidos, creo que nos va a dar la fuerza para poder continuar en este camino de la eliminación. En los programas de trasplante, la sociedad civil, sociedades científicas, para que podamos seguir internalizando todas estas problemáticas que se ven desde las estrategias y desde los pacientes que vamos a acudir a los centros de salud. Así que creo, para finalizar, que lograr las metas 2030, cumplir con los compromisos asumidos a nivel global, la atención integral de salud y el acceso a los tratamientos existentes es parte de estos compromisos, y a pesar de cambios políticos, como les decía, económicos y pandemia, seguimos avanzando en Argentina en una estructura sólida, y el estudio que ha hecho la coalición de eliminación para las hepatitis virales nos ha ayudado mucho en este sentido para poder mostrar al mundo en donde estamos avanzando firmemente hacia la eliminación con una estructura sólida para eliminar la hepatitis viral. Muchísimas gracias.
Muchísimas gracias, María Eugenia, por tu presentación, pero sobre todo por el trabajo que venís haciendo desde hace tantos años. Es simplemente, te sale del corazón todo lo que estás leyendo, lo que se hizo, y uno es testigo de todos los progresos que se han vivido en el país. Así que gracias por tu esfuerzo. Estamos cerrando, no tenemos tiempo para... De nada. Estamos atrasados en el tiempo, así que no tenemos espacio para preguntas. Hay un pool para evaluar la actividad, que me parece que es muy importante que se tomen su tiempo y lo llenen. Y me animo a decirles que lo hagan con ojo crítico, porque siempre uno tiene cosas para aprender cuando desarrolla nuestras actividades, donde cree que está brindando lo que el otro necesita, y por ahí lo que el otro necesita es un poco diferente a lo que uno ha planteado en el webinar. Así que con mucha confianza y mucho cariño expresen realmente lo que piensan. Creo que hay muchísimas conclusiones que se podrían sacar de este webinar, pero de nuevo, no nos da el tiempo. Yo quisiera agradecerles a todos los que hicieron sus ponencias. Me parece que es muy rico para todos poder mostrar lo que hacen los países líderes y ver dónde estamos parados los demás, cuán lejos o no estamos y cuáles son las estrategias que se adecúan más a cada uno de nuestros países y subsistemas, como decía María Eugenia, ¿no? Entonces, el poder compartir experiencias definitivamente nos va a enriquecer a todos y nos va a ayudar a cumplir con los objetivos de la OMS. Yo siempre me quedo con esta inquietud, con el sesgo propio de un asistencialista. ¿Cuál es el rol en este ecosistema de las sociedades científicas para, así como la sociedad civil es clave, los ministerios son claves, desde dónde una sociedad científica junto a una sociedad civil pueden apuntalar a las actividades que planean OPS, OMS y los ministerios? Me parece que eso también es un punto clave para acelerar el proceso de la eliminación. Y por último, agradecerle a John Ward y a la Coalición para la Eliminación de las Hepatitis Virales, que nos da este ámbito donde escucharnos, que nos ayuda a ordenar los pensamientos, a presentar la información, a compartir la información para tener un lugar donde todos juntos podamos crecer. La experiencia que yo me llevo es muy rica, es de team building, ¿no? Ir armando equipo, porque esto definitivamente no lo va a resolver un ministerio, una política, la sociedad civil, la sociedad científica, lo tenemos que resolver entre todos juntos. Así que, John, tus palabras de cierre cuando quieras.
Thank you, Marcello. Thank you, Alexei, for moderating. I thank all the speakers for their excellent presentations of highly effective programs in the Americas, demonstrating the key components of effective hepatitis elimination programs, national policies, strategies appropriate for the country, targeting key populations, seeking simplified models of care to be integrated within existing health systems. Truly great lessons to be shared and adopted elsewhere. The goal of this webinar is to promote this community of practice throughout the Americas. Please let us know in our evaluation what are the new topics that we could touch on in follow-up webinars so that we can really build this community of practice and work together more strongly to achieve the goals that are possible and prevent premature death from hepatitis B and hepatitis C. I want to thank you all again for participating in this webinar. We look forward to working with all of you closely as partners in the coalition and this community of practice for the Americas. Again, please fill out the evaluation form. I have to end by saying how impressed I was by the strong participation, even though we went much longer than we had planned. So I thank you all for your strong interest in hepatitis elimination. And it's this demonstration of interest and this openness to work together that I know makes hepatitis elimination possible. Thank you again for your participation, and I look forward to working with all of you in the future. working together, we will eliminate hepatitis. Thank you very much.